Hey there, and welcome to another deep dive.
Great to be here.
Have you ever paused to think about the incredible, often invisible, network of life-sustaining highways within your own body?
It's truly mind-boggling when you stop and consider it.
Well, today we're not just mapping a single road. We're taking a shortcut, really, to understanding the entire bustling intersection that is the internal iliac artery.
Ah, yes, a central hub of blood supply to your pelvis.
Exactly. Think of it as the ultimate traffic controller for everything from your bladder to your deepest muscles.
Indeed. Our mission today is to explore this remarkably critical artery, its intricate branching system.
The off-ramps, so to speak.
Precisely. The surprising clinical importance of each major off-ramp and the precise surgical maneuvers directly tied to navigating its pathways.
Okay.
You'll find it quite astonishing just how much fundamental anatomy underpins complex medical decisions in such a compact, vital area.
So grab your metaphorical map, because we're about to unpack some truly fascinating facts and surprising insights. We'll see why this knowledge is vital for everything from preventing major complications in surgery to simply appreciating the sheer genius of human anatomy. Let's jump in.
Let's do it.
Okay, let's unpack this. When you say internal iliac artery, I immediately picture a major highway junction in the body's lower half, like a real central point.
That's an excellent way to visualize it. It really is.
Can you tell us where this superhighway begins its journey and what its overarching mission is?
Sure. The internal iliac artery truly is a critical artery. It originates from the common iliac artery,
Go.
around the L5-S1 vertebral level, essentially low in your back where your spine meets your pelvis.
Got it.
Its primary role? Well, it's to ensure a robust blood supply to the pelvis, the perineum, and it even extends to parts of the lower limb.
And just for clarity for our listeners, when you mention the pelvis and perineum, what exactly are we talking about there?
Good question. So the pelvis is that large bony structure at the base of your spine, containing organs like the bladder, reproductive organs, and rectum. The perineum is the diamond-shaped area between the thighs. It encompasses the external genitalia and the anus.
Okay, so a really crucial zone then.
Incredibly vital, yes. And what's truly fascinating about the internal iliac artery is how it almost immediately divides.
Splits off.
Yes, into two major routes, an anterior and a posterior division. Each one has its own significant network of branches.
Wow.
And understanding this initial branching is absolutely paramount. It's key for preventing major complications during any pelvic surgery.
So if we're thinking of this as a highway system,
Okay.
let's take that first fork in the road. The posterior division.
Okay.
It sounds like this route is primarily taking care of the deep structural stuff, the foundational support of the pelvis, right?
That's an excellent way to conceptualize it. Spot on. This division primarily supplies the pelvic walls and the powerful gluteal region.
And there are specific branches we need to know.
We have three particularly key branches stemming from this posterior division that surgeons always have on their mental map.
All right, let's start with the first one, the iliolumbar artery. What's its primary function, and why is it on a surgeon's radar?
Okay, the iliolumbar. It supplies important deep muscles like the iliacus, psoas major, and quadratus lumborum.
So core stabilizers.
Essentially, yes. The core muscles that stabilize your lower back and hip. Clinically, it's a known potential source of bleeding, especially in the case of complex pelvic fractures.
Ah.
And the insight here is that due to its location, a bleed from this artery can be deceptively hidden. It can accumulate deep within tissues.
Making it hard to spot.
Exactly. Making diagnosis and control particularly challenging and complicating recovery significantly.
Wow, okay, so a seemingly small branch, but potentially a huge problem.
Definitely.
Beyond supporting those powerful muscles, our map then leads us to the lateral sacral arteries. These sound like they serve the sacrum itself.
They do, and its delicate network of nerves, the name gives it away.
What's the critical concern here? What can go wrong?
Well, these arteries supply the sacrum, that triangular bone at the base of your spine, and the sacral nerves passing through it.
Right.
An injury to these, say from trauma or maybe during surgery, can lead to what we call sacral plexus hematomas.
Hematomas, like internal bleeding.
Yes, think of it like a growing pressure balloon of blood, but in a very confined space directly pressing on these critical nerves. And this can result in significant neurological implications. We're talking severe pain, numbness, even impairing bladder and bowel control.
Which is incredibly serious.
Absolutely.
Okay, and then the third one in this posterior group is the superior gluteal artery.
Mm-hmm.
I imagine this one is incredibly important for the powerhouse muscles of our backside, the glutes.
It truly is. It's actually the largest branch of the posterior division.
The biggest one.
Yes, it makes its exit from the pelvis via the greater sciatic foramen, specifically above the piriformis muscle.
Okay, location matters.
Critically. And it provides the main blood supply to the robust gluteal muscles. But here's where it gets really interesting for practical application.
Yeah.
It's incredibly important in reconstructive procedures, particularly in what we call gluteal myocutaneous flap surgeries.
Flap surgeries.
Yeah.
Like moving tissue around.
Exactly. So if you ever wondered how surgeons can take tissue, complete with its blood supply, from one area to reconstruct another, well, this artery is often the star player.
Because it's reliable.
Its reliable anatomy makes it a surgeon's best friend for restoring function and form after, say, trauma or cancer resection.
That's fascinating.
Yeah.
So we've explored the structural highways, the posterior division supplying the foundation.
Mm-hmm.
Now let's shift our focus. Let's talk about the more intricate service roads branching off the anterior division.
Okay, the other main route.
Yeah, leading to some of the body's most vital internal organs and sensitive areas. This sounds like an even denser network.
It absolutely is. The anterior division supplies the pelvic viscera, that's your internal organs in the pelvis.
Right, bladder, rectum.
Exactly. Plus the perineum, which we discussed, and even parts of the medial thigh. It's quite the comprehensive network indeed.
Okay, let's dive into its branches then. First up, the umbilical artery. Isn't that a bit of a blast from the past? Reminds us of, before we were born.
It is indeed. But here's the kicker, the real insight. Even after it largely transforms into the medial umbilical ligament post-birth.
So it mostly closes off.
Most of it, yes, but it retains a vital function. It gives off the superior vesical arteries.
Which do what?
They supply the top part of the bladder. It's a testament to the body's incredible recycling, really.
How so?
Well, a major fetal vessel doesn't just disappear, it repurposes itself. And its remnants can even be used as crucial surgical landmarks in adult surgery.
Wow, so it's still useful.
A truly fascinating, ongoing transformation.
That's a great example of the body's efficiency. Okay, next, let's talk about the obturator artery.
Ah, the obturator.
I hear this one has a famous, or perhaps infamous, connection point. What makes it so noteworthy?
You're probably thinking of the corona mortis, right?
That's the one. Sounds ominous.
It can be. The obturator artery itself travels through the obturator canal, alongside the obturator nerve, supplying important adductor muscles in the thigh.
Okay, standard stuff.
But the corona mortis, the crown of death, is where things get intensely clinical.
Why the dramatic name?
It's a variant anastomosis, basically a natural, sometimes unexpected, shortcut or direct connection between blood vessels.
A variation. Not everyone has it.
Exactly. It's a connection specifically with the external iliac artery system, and it crosses right over the pubic bone where surgeons might be working during hernia repair.
I see the problem.
Imagine it like a rare, unmapped bypass road that, if nicked unknowingly, can turn a routine procedure into a crisis.
Because of bleeding.
Massive bleeding potential. Its presence dramatically increases the risk of life-threatening bleeding during hernia repairs or even pelvic fractures. It raises a huge question for surgeons. How do these individual anatomical variations fundamentally change our approach to patient safety? You can't just assume the textbook anatomy.
So it's not just about knowing the standard map, but also being acutely aware of these rare, high-stakes detours.
Precisely. That's a powerful point. Vigilance is key.
Okay. Now, the anterior division also gives rise to a cluster of specialized arteries, vital for many of the pelvic organs and structures below.
That's right. A whole group of them.
What are some of these, and why are they so important?
Absolutely. We're talking about arteries like the inferior vesical artery in males, which supplies the bladder base, prostate, and seminal vesicles. And then its female counterpart, the vaginal artery, supplying the vagina.
Makes sense.
Then we have the middle rectal artery. This one forms crucial connections, anastomosomoses with other rectal arteries.
So, important for bowel surgery.
Yes, very important in rectal surgeries,
Wow.
and also when dealing with things like hemorrhoids. These might seem specific, but their consistent presence and role make them key landmarks and sometimes targets in respective surgeries.
Targets meaning?
For instance, the inferior vesical and vaginal arteries are often carefully ligated, meaning tied off during major procedures like radical prostatectomy or hysterectomy to control blood flow.
Right, you need to manage bleeding.
Essential.
It sounds like each of these plays a very precise role, and surgeons need to know exactly where they are.
Without a doubt.
Let's move on to the internal pudendal artery. This one sounds like a very specific, important pathway, and I hear it takes quite the scenic route.
It certainly does. It's often called the main artery of the perineum.
The main supply down there.
Pretty much. It takes a circuitous route. It actually exits the pelvis via the greater sciatic foramen, almost leaves the area.
Really? It leaves?
Almost. Then it loops back, re-entering through the lesser sciatic foramen to reach its destination.
Huh. Why the detour?
That's just its anatomical course. But it's critical because it supplies sensitive structures, like the penis or clitoris, via its dorsal artery and the anal canal.
So its preservation is key.
Paramount in many specialized surgeries. Absolutely vital.
We discussed the superior gluteal artery earlier, supplying the glutes from above the piriformis. Right. Now, what about its counterpart, the inferior gluteal artery?
Good point. The inferior gluteal artery complements the superior one perfectly.
How so?
It exits below the piriformis muscle and also supplies the gluteal muscles.
So also important for those flap surgeries.
Exactly. Like its superior sibling, it's another important player in complex gluteal flap surgeries. It gives surgeons additional options and, frankly, redundancy in reconstructive procedures.
Having options is always good in surgery, I imagine.
Definitely.
And now, for one that seems particularly famous in surgical circles, often with its own memorable adage, the uterine artery.
Ah, yes, the water under the bridge artery.
That's the one. What's the story there?
Okay, so this artery, found only in females naturally, it runs within the broad ligament.
Which supports the uterus.
Correct. And, crucially, it uniquely crosses over the ureter, the tube carrying urine from the kidney to the bladder near the lateral cervix.
It crosses over the ureter.
Yes. Think of the ureter as the bridge and the uterine artery as the water flowing under it. No, wait, I got that backwards.
Happens to the best of us.
Right. The uterine artery crosses over the ureter, so the ureter is the water under the bridge.
Ah, okay. Water, ureter, under the bridge. Uterine artery. Got it. Why is it so important?
Clinically, this anatomical relationship is one of those memorable details surgeons never forget. Because it means the ureter is significantly at risk of being accidentally clamped or cut during a hysterectomy or other pelvic surgeries when you're trying to ligate the uterine artery.
Wow. A tiny structure. Huge potential complication.
Exactly. The insight here is that a surgeon's knowledge of this one specific relationship can literally prevent a life-altering complication for the patient. It's that critical.
The water under the bridge. That's such a vivid image for a critical anatomical relationship. Really highlights how a single detail can dictate the approach.
Absolutely. It's a classic example.
Okay, finally, we briefly mentioned the rectal arteries earlier, but let's make sure we highlight the inferior rectal artery. What's its specific role?
Right. The inferior rectal artery is actually a specific branch of the internal pudendal artery, which we just discussed.
Okay. Part of that system.
Yes. It supplies the external anal sphincter and the lower rectum. So it's directly involved in the complex network around hemorrhoidal issues, and its precise location is essential for any procedures in that very sensitive region.
Understood. Wow. We've just navigated this incredibly dense network.
It is quite a map.
From the structural arteries of the posterior division to the specialized routes of the anterior division leading to vital organs, it's crystal clear that this isn't just academic knowledge.
Not at all.
It's a lifeline for surgeons. So let's turn our attention now to how this intricate map directly guides their hands in the operating room.
Right, the practical application.
What are some of the most critical surgical maneuvers directly tied to the internal iliac artery and its branches?
Absolutely. The application of this knowledge is truly where the rubber meets the road. One major procedure is internal iliac artery ligation.
Ligation. Tying it off.
Yes, exactly. Also known as hypogastric ligation. Hypogastric is just another name for the internal iliac.
Okay. When would such a critical intervention be performed? That sounds quite drastic.
It is reserved for critical situations. Think severe postpartum hemorrhage that's excessive bleeding after childbirth.
A major emergency?
A huge emergency. Also, severe pelvic trauma with uncontrolled bleeding, or sometimes doing certain complex uterine fibroid surgeries.
And what does tying off such a major artery achieve? Doesn't that cut off blood supply?
That's the crucial point. The effect is remarkable. By ligating, essentially clamping off the main trunk of the internal iliac, it drastically reduces the overall blood pressure in the downstream pelvic arteries.
Pressure, not total flow immediately.
Precisely. It reduces the pulsatile flow significantly. This buys time by allowing the body's incredible natural collateral circulation.
The backup roads.
Exactly. Think of it as activating all the smaller backup roads and detours. These collaterals can often maintain enough blood flow to vital areas while the main source of hemorrhage is controlled.
So you're leveraging the body's inherent adaptability.
In a life-or-death situation, yes. It's quite elegant in a way.
That's fascinating how the body has these natural bypasses built in. Okay, and what about uterine artery ligation? How does that differ?
Uterine artery ligation is a more specific procedure. Here, we're targeting just that single crucial vessel supplying the uterus.
So not the main trunk.
Correct. It's performed during situations like cesarean hysterectomies or for managing uterine fibroids directly. And again,
Let me guess. Water under the bridge.
you got it. Extreme care must be taken to avoid injuring the ureter. That anatomical relationship is always, always top of mind during this procedure.
It keeps coming back to that specific point.
It does. It's fundamental.
Okay, another powerful technique you mentioned is embolization of internal iliac artery branches. This sounds less invasive than open ligation.
It is. It's a minimally invasive approach, usually done by interventional radiologists, not surgeons in the traditional sense.
How does it work?
Instead of open surgery, they guide a tiny catheter, usually through an artery in the groin, all the way up to the specific bleeding branch within the pelvis.
Wow, like navigating tiny tunnels.
Pretty much. And then they deploy tiny particles, or sometimes small metal coils, to block the blood supply just to that specific area.
So very targeted.
Extremely targeted. It's used in situations like postpartum hemorrhage, pelvic trauma, and also for treating certain tumors non-surgically.
Any common examples?
A prime example is uterine artery embolization, or UAE. It's a widely used and highly effective treatment for uterine fibroids and adenomyosis.
How does blocking the artery help with fibroids?
By blocking the blood supply specifically to the fibroids, it causes them to shrink, and symptoms often resolve without needing a hysterectomy.
That's a great alternative for many people.
Absolutely, a major advance.
So it's about a very precise, targeted blockage. Now, we talked about the corona mortis earlier, that dangerous variation.
It's the crown of death.
What about the management of obturator artery bleeding when that specific vessel or its connection is the problem?
Right. If bleeding occurs from the obturator artery itself, or especially from that corona mortis connection during, say, hernia repair or pelvic trauma, well, it requires extremely rapid and decisive control.
Because it can bleed so much.
Yes. Unchecked bleeding in this specific area can lead to exsanguination, a life-threatening, massive loss of blood very, very quickly.
So immediate action is needed.
Absolutely. It's a stark reminder that even a small anatomical variation, if not anticipated or recognized quickly, can have profound surgical implications.
Finally, let's talk about the preservation of the internal pudendal artery. You mentioned its role in supplying very specific, sensitive areas earlier.
Precisely. Unlike some other arteries we might sacrifice or ligate if necessary.
Like the main internal iliac trunk in an emergency.
Exactly. The preservation of the internal pudendal artery is absolutely crucial in highly specialized procedures. Such as gender-affirming surgeries, various complex pelvic reconstructive surgeries, certain cancer operations.
Why is it so critical to preserve it?
Because maintaining the integrity of the pudendal artery is vital for nerve function and blood supply to the external genitalia and perineal structures. Damaging it can have significant consequences for sexual function, continence.
So quality of life is heavily dependent on it.
Immensely so.
Yeah.
It highlights its diverse and critical applications in modern medicine and really emphasizes the highly individualized nature of surgical planning in these cases.
It really underscores the need for precision.
Precision and detailed anatomical knowledge.
So what does all this mean for you, our listener? We've just taken a really deep dive into the internal iliac artery.
A central hub, indeed.
Yeah, a central hub of pelvic circulation, exploring its intricate branching system. From the iliolumbar artery, which can bleed deceptively in a pelvic fracture, to the uterine artery, with its famous water under the bridge relationship with the ureter.
A classic.
We've seen how understanding each one is like having a vital map for surgeons navigating some of the most critical and delicate procedures imaginable.
Absolutely. Knowing these pathways, these specific anatomical relationships and their clinical implications, it isn't just academic. It's not just for exams.
Right. It's real-world stuff.
It truly underscores how fundamental anatomical knowledge is for ensuring patient safety and for achieving successful surgical outcomes.
Yeah.
It's really a testament to the incredible, complex design of the human body.
And the skill needed to work with it.
And the constant learning and precision required to interact with it effectively and safely.
That leaves us with a final provocative thought for you to mull over.
Okay.
How do such intricate, ancient anatomical relationships, refined over eons of evolution, continue to not only inspire new surgical innovations today, like embolization techniques or nerve-sparing surgeries,
Building on that knowledge.
but also, surprisingly, still present unexpected challenges and unique detours, like that corona mortis, in the operating room, forcing surgeons to continually adapt, innovate, and sometimes just be incredibly careful.
It's a constant interplay between established knowledge and unexpected reality. A fascinating thought.
Thank you for joining us on this deep dive into the human body's incredible design.
My pleasure.
Until next time, keep exploring.